Good morning, everybody, and thank you for inviting me here. I'm going to talk about the electronic prescribing that we adopted in our hospital. Before I do that, could I just ask, maybe I'm talking to converts, and it would be helpful for me to know, out of the audience, how many people are in hospitals where it's wall-to-wall electronic prescribing already in place? Okay, so would it be fair to say less than 10%? People are already kind of experiencing it. And since this is a case study, it's not going to be kind of full of data. It will be more of an experience, a journey. And I would like all those who have had the experience to please join in and share your experience somewhere, because I think experience by nature is a subjective thing. Well, we had this transition from 2007, 2008 till 2010. So what I'll do is I'll briefly tell you about where I work and what's so peculiar about Leicestershire Partners Trust, and we'll then quickly go through journey. And I'll leave a lot of time in towards the end for that kind of sharing of experience. I hope that will be better rather than me bombarding you with information. Since Leicestershire is up north somewhere in the middle of nowhere, I thought I'll put it on the map just for people to know where it is. It's a prototype British English countryside, and we are in the Midlands. Leicester actually is a population of around 1 million in Leicester, Leicestershire and Rutland. As a mental health and learning disability trust, we, unlike some of the acute hospital, have 120 different physical buildings or structures from where we operate. We had, before 2011, we had nearly 3,000 staff with us. And of course, within the last 18 months, we emerged, and we are now, along with the mental health and learning disabilities, we are also a community healthcare trust along with it. But when this electronic prescribing was being rolled out, we were entirely a mental health and learning disabilities trust. And here are just some of the numbers of what kind of people we are talking, which I guess in some sense of the acute hospital might be small. But if you combine smaller number with wider geographical spread and wider bases to operate, you can imagine the complexities and the interactions and the problem for errors happening all the way. Arguably, being a psychiatrist, we use some of the most dangerous drugs, mind-bending drugs. And a lot of them are not just for 10 days with a 4 weeks post follow-up. We are talking about months, years, lifelong. And so you can imagine, when it comes to manual prescribing, what a complex machinery there must be. And you can imagine what kind of scope for error and the impact of that error on people's lives and well-being would be. Basically, before 2007, we were like anybody else, and a typical inpatient manual prescribing, and all of you are familiar with these steps, so I need not harp upon it, but certainly in electronic prescribing term, the second and the third step certainly is an unnecessary step, which all of us were sick of, but we couldn't avoid it. Our pharmacy was at least 5 miles from our base, sometimes 11 miles away from our base. We used to have those pharmacy vans coming and going, faxes running on an overdrive, drug card being faxed back and forth, sometimes poor quality handwriting, poor quality fax, staff shortages. It will take a long time before something comes back to us. And by then, if you change the medication, the whole cycle gets repeated before a meaningful treatment could be started. Our patients also, a lot of them, are extremely vulnerable and are more at risk of errors in taking drugs anyway. So this is all compounding effect of one after another. Doctors who used to come had different habits. The handwriting was not the best. If the handwriting was good, it was questioned whether they are genuinely doctors or not. Sometimes patients came with a cocktail of 20 different drugs in heart and kidneys and everything, and some of the psychiatric doctor had no clue how the drug interaction work. The BNF was the only thing, but in the busy life, you can imagine how many times we open the BNF. Sometimes the national guidelines, the NICE guidelines come about, but it would take many months before they sink in. So the practices, the old habits kept on going. And then there was cost implication of brand prescription versus generic prescription. Should it be Tegretol or should it be carbamazepine? And so on. Without again dwelling on them, all of them are something which you will be familiar of, the kind of delays and problems. In 2007, we were getting increasingly disillusioned by this 10-year promise of, what was it called? NP Fit. Anybody heard of that? Yeah? Well, we were into it very, very seriously from 2001 onward. But by 2007, we were kind of struggling to feel ourselves enthusiastic. We thought, hold on. We can't just go on like that and then this kind of imaginary gift we'll get. And so we started a process. We agreed that we will use a system whereby we will change from being manually prescribing trust to complete electronic prescribing. I think the key to this was our executive team's commitment. I think that if there's one thing, if your exec directors are taking it seriously, you're more likely to get it. That's a bottom line. Of course, once we made up our mind that we want to do it, we looked around and there's a product from JAC which we chose. And again, there are other products, and I'm aware that within Leicestershire, the acute hospitals have chosen a different product, and we'll talk about that briefly in the end. And we had extensive clinical engagement. That was one thing, and that was because all the clinicians themselves were fed up of the delays, inefficiencies, errors, you name it. And we knew we had to run pilot because nothing succeeds like success, and we had to show that it makes a difference before the wider clinicians and managers were adapted. And so we had to run some pilots to demonstrate that it does make life easy, and it is safe, and it is efficient. Of course, there is the initial cost of setting it up and adapting. Change management is a very popular management jargon, and we had to kind of live with that and make people sort of accept that there is a kind of benefit of that change. I think the e-prescribing in some of the other trusts where this product was used, we got less than enthusiastic feedback. And we learned from that. And I think one of the key messages we learned was what helps is that hand-holding in the middle. At 12 midnight, if your junior doctor is struggling to write something, he needs help there and then only. No good waiting till 9 o'clock next day morning. If your system is crashed, well, it's no good because it's going to cause so many people to get totally disillusioned and fed up with it and start using paper again. You had to take people's concerns seriously. If there's somebody rings you to say, doctor, this is a problem, you can't say, oh, that's because you don't know how to open a computer or how to click a button. Although that might be the case, you don't say that. But over the period, as I said, within 4 months, it was obvious the junior doctors who were the kind of most directly affected by this could see the benefit that electronic prescribing does. When they're in their junior doctor's room and the nurse from the ward, which is half a mile away, calls them, they don't need to go there to write a drug, which they could write from their own base. Saved them a lot of toing and froing. Pharmacists didn't need to wait for somebody to fax that prescription and then whole thing to be delivered. So you could get the medicine delivered to different wards much more quickly. And the end result was boards and the doctors and the clinical directors were demanding to roll it out to their own units and bases. And we had a problem because we were very keen that we do not want to dilute our support. We had 2 or 3 people to provide that 24/7 support. We wanted to make sure that the intensity and the quality of support is not diluted by spreading it out too quickly, too widely. So the whole project was a 3-year project to roll it out we started with from 2 wards and ended up spreading eventually to 34 wards, which were spread all across the place. And really, that was one of the most satisfying things to see that I didn't have to go and tell anybody, please take it, because they were coming and telling me, when can we have it? But of course, that also meant for a period of 2 to 3 years, we were living in these two parallel worlds, where within a big building, half of the wards were electronic prescribing, half of the ward was still doing the thing, and it caused a lot of friction, and you had to manage that, you had to be with them, you had to acknowledge their distress, frustration, that they're switching hat every working day. Eventually, we did get there, thankfully, and for the last nearly 2.5 years, every clinician who joins us gets a secure access. Every induction has a dedicated slot for electronic prescribing and registration. We do not do any paper prescribing. However, in the last 3 years, I know of 2 incidences where the system crashed. And on both the occasions, it was possible to print out, and just for 12 hours or 6 hours, we had to cope with that. That's the nature. You have to have an emergency backup system still running. Hopefully, it hasn't happened for 14 months now. The last I remember was beginning of last year sometime. What we also managed to do, which was quite helpful, was within the electronic prescribing, not only that it is a mandatory generic prescribing, unless you want to specifically on a case basis want to prescribe a brand drug, and there might be good clinical reasons to do that. We also have automatic, all the BNF data is there, so any drug interaction, any incompatibility issues, any dose limitations are flagged up as soon as you write a drug which is at odds with something or another. So the doctor can positively override that, but at least that's a positive decision as opposed to them not knowing and just carelessly writing something. We also have NICE guidelines, BNF, and local prescribing guidelines on the system so that you don't need to search for it. Within the system, you can find it. And I'm sure I'm not the best person, but pharmacists are more than happy because they can keep track of their stocks and flow of the medication in real time much more effectively. For the last 2 years, once we succeeded in our inpatient, we had complete inpatient prescribing, and the system was quite perceived to be extremely beneficial. We started rolling out for community outpatient prescribing. We started, all the clinics have printers and FP10 printers, and so all the prescription begin outpatient are also electronic, so that it's all recorded centrally. We can set up long-term prescription just like most of the primary cares and GPs can do, where you can do a 6 months or longer prescription and gets repeated every 3 months. We can set up mandatory fields. So if a new patient is entered for prescribing, you could set some minimum information which must be entered before the person is allowed to prescribe, such as whether there are any allergies or not, whether it's a prescription which is under the shared care and to be handed over to GP or not, and you could actually make it customizable what your organization feels is necessary. We also realized that since we are writing all these drugs on this, it's a bit silly for doctors at the point of discharge to then write them again on a discharge letter. And so we had a different patient administration database. We had this pharmacy, the JAC database, and we, with some bit of cajoling and pressure, we managed to get somebody to get them to talk to each other nicely so that we could come up with a discharge letter which is automatically produced electronically. We don't need to rewrite, any of the doctors don't need to rewrite drugs. Whatever is on the JAC comes straight into a discharge template. Saved time, was popular, errors were minimized, and it took us another 12 months before we could actually electronically transmit the data, because although we were producing it, we still had to print it out, sign it, post it or fax it, because the primary care system and this system weren't compatible with each other. But all in all, we have reached there, long journey, I must say, but it gives enormous satisfaction that we are eventually reaching that point. Again, a lot of these are self-evident, I don't need to spend much time on them. Where are we going to go from here? Well, as I just referred to, we have an acute hospital next door to us who uses a different system, and the two don't talk to each other. We have a primary care system with whom we have just about started talking, and we can start sending the information, but we are yet to have a system where we can get the data from primary care into our JSA. So it's a one-way flow of traffic. There's still work to be done there. As you noted right at the beginning, we are now merged with community healthcare. They have community hospital. That system is the third system. And within our trust, we have got these two systems. So it's a measure. So lots of interoperability, and those issues are still relevant. And we are embarking, as we speak, on electronic patient records, but we'll still carry on with the e-prescribing for foreseeable future for reasons of specific limitations of different systems. And that's a challenge. In the next 12 months, we should be using an electronic patient record, complete record, and how do we integrate the two? And the last of the issue, which is still unresolved, I'm a community consultant, so half of my time I'm out in the countryside driving through some lovely villages, and I still have to carry my FP10 with me because we don't yet have that mobile laptop-based e-prescribing facility. And it's a challenge. Again, how do we make it happen? It's a great in principle, but it's extremely slow in implementing. And these are some of just snapshots from the JAC. This is the opening, the screen prints. You've got, once you log in, you get all these things where you've got outpatient, inpatient, you can make inquiries. If you just want to find out and not necessarily prescribe, you can check some inquiry. And on the left-hand side, you can see lots of headings under which you can get lots of information within the JAC field. Each person, and this is my diary, as soon as you start writing, you can see, and I've blacked out the names of the patients on the diary. This was yesterday in the daytime, I copied it. You can see, you can go back to that patient, you don't need to search for it. Once you've done the prescription, if you want to change it or modify it, you can do it within that diary easily. You get alerts. You can make notes for pharmacists or anybody if you want somebody to be warned of something. There's a facility to provide them. And all the drugs which are current or past can be seen on the same screen. This is just various, as you can see, you can access the BNF, you can access some of the local guidelines, and if you're going to use unlicensed any medication, all the current guidelines, current protocols are there. And that's about it from my side. Thank you very much.